My name is Andreas Andresen, and I'm an orthopedic spine surgeon at the Department of Spine Surgery and Research at Middelfart Hospital in Denmark. I'm talking to you about my JBJS article, Instrumented versus Uninstrumented Fusion for Lumbar Spondylolisthesis, a randomized controlled trial. In our clinic, a tertiary spine center in the southern region of Denmark, the standard practice for patients diagnosed with degenerative spondylolisthesis is conservative treatment with physiotherapy and patient education. But for those of our patients where this treatment is unsuccessful, the standard treatment has been to offer instrumented fusions to patients younger than 60 and uninstrumented fusion to the larger segment of patients aged 60 and above, both in combination with decompression of the neural structures. This choice was based on an intention to minimize the surgical stress and potential risk for implant-related complications among our most vulnerable patients. With the addition of Professor Carrion to our research team, the choice of treatment was challenged due to a completely different treatment strategy at her institution in Kentucky, US. As we looked closer into the literature behind the decision, we found that results were conflicting with disputes in both patient-reported outcomes, fusion rates, and reoperation rates. Consequently, we decided to test our previous practice in a randomized trial where we attempted to eliminate some of the biases in the earlier studies. Patients older than 60 scheduled for fusion surgery due to degenerative spondy were divided into two groups. Patients had either the standard treatment of decompression and uninstrumented fusion or a similar decompression and fusion with the addition of pedicle screw instrumentation. All patients were followed for 2 years. When we opened the randomization, we expected to find a difference between the groups, but the difference in both reoperation and fusion rates was surprising to us. We did not find any differences in patient-reported outcomes at either follow-up. Our study suggests that if surgeons aim for a solid fusion, instrumented fusion would be the treatment of choice, regardless of the similar patient-reported outcomes. In our clinic, as well as in neighboring clinics in Denmark, practice has changed since we completed the study. In our case, instrumented fusion is now the treatment choice for elderly patients as well. In the current study, we did not investigate the need for fusion surgery in patients with degenerative spondy, but only the outcome of two different fusion methods. And based on recent research from our neighboring Nordic countries, it's likely that not all patients require fusion surgery in addition to the decompression. Going forward, we feel it would be interesting to look at further individualizing the choice of fusion versus no fusion, and to develop and test an algorithm based on patient data and imaging.